And we are officially live for episode 6, Pain in the Brain. So, welcome, one and all, to Just
Hi.
Massage Therapist podcast, where we are just massage therapists. We're just a bunch of other things as well, and we're just chatting. We're talking about things we want to talk about. We're getting the lives. There we go. I've got the Instagram is live now. She's working on her Facebook
It's
to
still
go
not up.
live. Does it say on your side that it is live?
It says I have the Facebook in the corner.
Oh, yep. There we go. I
Hi.
see the streaming there.
Winning.
Woo! That is exciting. Everything is working exactly how it is meant to work. I am just gonna go and I like to have it open on my phone so that I can see that. There we go. I like to know where we're at time wise, if we're like 30 seconds or 20 seconds or 15 seconds delayed. So, as per most of the times where we are on here, if you are watching us through YouTube or Twitch, we can generally see your chats like right away. If you're on Instagram watching us, I have to go back and forth. If you're on Facebook watching us, she has to go back and forth. So if it takes us a little time to respond to you, that is why, in case you were wondering. And of course, if you are watching this after the fact, hi, and thanks for coming back
Hi.
and checking us out. Yay. I feel very girly today. I tried makeup on from the spa. The owner of the spa, she also does her own line of makeup and stuff. So I'm actually wearing a little bit of foundation and a little bit of shadow just to see how it fared, because my eyes have a tendency to not to like things. But so far so good. My face is not having any issues. My eyes aren't getting really sore. Granted, I only put a little bit of shadow on, so this is the beginning, and we'll see whether or not. My husband just looked over and said, "Your face is a face."
Whatever, man.
Whatever.
Whatever.
uh, for those of you who have never heard him, talk at one of these things, he likes to try and make jokes. Doesn't always work. Okay. So today it's probably going to be a little bit of a shorter day. We're just going to talk about a couple of things in regards to pain, because it's literally my favorite thing to talk about. And Cora's had 2 weeks of things for her, so it's my turn.
She's not keeping tabs or anything.
No, not at all. Oh, speaking of pain, though, I do have a story. I have this one client who has sciatica, right? And in the few times that I've had her over the past few months, her issue is coming from the lumbar region, right? So lower lumbar region, and it is causing her. She said that it caused her so much pain about 13 years ago. She got a shot, right, the cortisone shot, and it didn't hurt for 13 years, and it all of a sudden came back this past month.
What changed in her life?
We've been talking, she thinks what she believes happened is that she's been spending a lot more time with her grandson, and he's young enough that she's been picking him up and been holding it. She thinks that she just sort of went a little too far, and it just again. So we've been trying so many things the past couple of months, and still haven't been able to figure this one out. This one's gonna be a tough one. So we tried all the normal things, of course, right? We tried doing some lengthening stuff, some stretches, but she can't even hold the stretches at this point.
Oh.
Yeah, I'm trying to do some SI joint stuff just to loosen up the area, and nothing. I went into, she can't handle much pressure at all, which has a lot to do with it. We tried to go a little bit into iliacus and psoas, and no, it was just not happening yet. We're gonna figure it out, but Not yet. Oh shoot! I'm making clicking noise. Thank you. Thank you so much for stopping me from making the weird clicking noises that you guys have to listen to. Blech. Mm. But yes, that sort of segues us into pain. Oh, the reason we all get into massage therapy. Let's be honest, right? I mean,
Well, we want to all prevent it, right? That's our
we want to
goal.
prevent it. We want to help people who are going through it. Pain is in my mind, the great equalizer.
You're not wrong. You're not
Yeah,
wrong.
everybody deals with pain, and everybody feels pain the way that they feel pain. We still haven't been able to. Nobody's been able to prove whether the pain I feel is the same as the pain anybody else feels.
Well, this is relative.
Yeah, it is all relative. We like what I see, what you see are different. The sensation is always going to be relative to the experience of the person. Yeah.
I love how unique everything is in that.
Yeah, that's pretty cool. Which is why we treat every single client as a unique individual with their own experiences in the world, right? And in their own body, and why we know that they know their body better than we do. We may know what everything's called, we may know how those things work, but we can't experience what they're experiencing.
Yeah, I've had some clients that are like, just, oh yeah, like I'm in a really hypertonic area and I know it hurts. Like, but they just don't even feel it because their pain threshold is so high. When I ask them what their scale is, it's like a 4. I'm like, this is a 4? This is like my 20, I'm sure.
Yeah.
And they're sleeping. And it's like, man, there's no way. But
Yeah,
there is.
absolutely freaking no way.
Like,
Oh my god. Uh,
yeah, like they're just, and maybe not actually a 20. I exaggerate, but like it definitely like up there. But I'm a suck.
yeah.
Like I'm a little wimp when it comes to pain too. So
I think that might be why the first couple of years, well, first few years actually out of school, I spent all of my continuing education time and set aside money on understanding pain better. I spent so much time reading into and taking classes and gaining more knowledge and education in how to work with pain in a way that doesn't cause pain. And that's kind of what I want to chat about. So everything that we sense in our body, doesn't matter what it is. Temperature changes, touch, vibration, tickle, itch, pain, movement, all the things that we feel are all interpreted up here, right? They're all they go through an interpretation route at the spinal cord and at the brainstem, and then once it finally gets to the higher centers in our cerebral cortex, we get to actually feel what it is that we're sensing. But it's all processed up here. It's all stored up in our brain in various different regions inside of our brain in the integration regions of our brain. How dare you? How
sorry.
dare you need to cough while I'm talking and monologuing?
Apologize.
It's fine. It's totally fine. One of the things that going through as much as I've gone through and understanding a little bit more on how our nerves literally take in pain and store it inside of our brain and store it inside of our bodies. I have found various different weird ways to decrease pain, right? To take the interpretation that you have of pain and take it from a 7 to 4. So although the thing that is causing that pain may not be completely done, right? It might be on the way out. It might be going through the final stages of healing and fixing in that area, but your body is still in that like, oh, there's pain mode, so I'm going to keep it up here. It's high alert still, even though it's starting to fix it. We go from high alert to like yellow, red alert to yellow alert, faster than what your body would normally go through. And that's one of the things that I think most of us don't think about is that we, as massage therapists, when we are treating and when we're trying to help people get through pain and deal with pain, is that we're not fixing whatever it is that's causing that sensation to go through and up into the spinal cord and then up into the brain. We're not stopping that. We literally don't stop that. We can't. We don't have the tools to do that because it's chemical. Right? There's very little physical pain under the surface of our skin. Most of the pain that we feel underneath our skin layer is chemical pain. So we don't have the ability to actually end that pain for people. What we do have the ability, though, is to help the brain recognize that, oh, it's not a red alert pain situation. That's why we never do anything in an acute period, because anything that we do is just going to cause technically more pain signal.
Mhm.
Because we're just adding insult to injury in an acute period. And in the chronic period, when the brain is still on high alert where it needs to start coming down, we just help it cool down faster. Right? So this whole idea of massage therapists fix things. Well, no, we don't fix things. We
Facilitate.
we facilitate healing. We tell the body, "Hey, this area needs your help," but also you don't need to be in fight or flight. You don't need to be in red alert for this anymore either. Come down from that, but still fix the area. I don't know. I think that's why I find pain and the brain kind of interesting. What
It
have you?
is
What
very,
have your experiences been? A little bit.
like for me personally,
Mm.
well, I don't usually experience a lot of pain. So when I do, I just am always suck. Like I said before, like if I'm in pain, I'll just be like, oh, my shoulder. It's like, okay, I, okay. But then it's like, no, you got to move it. So I move it, I'm like, ow, ow. And then it doesn't hurt for very long because it's usually just me sleeping dumb. But I'm just a suck. But like when I'm getting treated, especially with the psoas, because it's brutal,
Mm.
I just kind of start thinking about actually, no, I give myself permission.
To do what?
Relax.
Oh, that's nice.
I give that muscle permission. And while I'm giving that muscle permission, I'm thinking about butterflies and rainbows and in with the butterflies, out with the bees. That's actually my thought process. I'm like, it's
I
okay to
like that
relax.
mantra.
In with butterflies,
The
out with
butterflies
the
out with the
bees.
bees.
And
That's a
then,
neat one.
so I kind of just like distract myself from it, I think. And then the gate control theory pops up, or like the different theories between pain, like the distraction and the different stimulations that are happening. I just
Mhm.
they become more aware of those than what's actually happening with the muscle.
That is pretty cool. I love that you brought up the gate control, because the gates are people think about the gate control because we teach it, right? We teach the absolute basics of gate control theory in school, where it's like at the level of the spinal cord, there are gates that can open and close, and we can do things to help close or open those gates, right? Like we can cause a cascading chain reaction to help close or open those gates, right? But the truth being is there's a gate right at the location where you're sensing it. There's a gate with the autonomic nervous system also really close to that and in the gut. And in the level of the spinal cord for both the muscle or whatever's hurting, muscle, ligament, tendon, whatever it might be. In the spinal cord, there are multiple gates there. And then you come up to the brainstem, likely a gate there. And then you get into the brain, cerebral cortex, there's likely another gate there. So we talk about the gate, and it's a theory. Please understand, gate control is still a theory. It's not something that has been 100% proven or anything like that. It is still it's gone past hypothesis to theory level, right? It's been theory level for decades at this point.
It
But
probably
it's
always will be.
I really believe so. So when you're looking at the transmission of signals, electrical signals, the way that we are able to understand that is because of a giant octopus. There was a giant octopus, and they found nerves that they could actually physically work with. They were big enough to actually put little probes in and discover how our nerves, well, how nerves respond, right? And they've taken that, and this is ages ago. This is ages. I'm talking like 50 years ago. This is ages ago where they found this. So more than 50 years actually. I keep forgetting we're in the 2020s. So this
It
was
was 50 years.
it was 50 years. It's probably more like 70 or 80 years ago now.
Okay.
And they took electrical probes, literally, and they would put them in, and they would watch the electrical change when they basically fed it certain things, right? And those certain things would be positive or negative charges. And what they found was sodium and potassium were the big two negative charges, sometimes chloride and sometimes calcium. They were the biggest negative and positive charges to move around. Now, chloride is the only negative charge there. The other three are positive charges. And if you had a specific amount of it, it would change at that location, and they would notice that it would change the next step or the next surface area. So if one part of the surface area was here, it would change here. And then if this area here was allowed to have the electrode changes, right, or the electrical changes, it would alter something here. And it would just go and go and go all the way down if the circumstances were correct. So they took that model and they applied it to humans, right? Going, well, our nerves kind of look like this, like they're set up very similarly, and over the years, and with technology allowing us to see things that we couldn't see before, and recognizing that okay, these do actually work very similarly to each other, very different how they communicate with each other than what they thought back then. But the more that they were able to understand that and see how things developed, the more they could theorize about how we transmit impulses of information. I mean, think about it. All we are is a bunch of flesh and electrical impulses. Some of those electrical impulses allow us to contract muscles. Others of those electrical impulses allow us to take a message from here to here, and then from there to here, and then here to here, and so on and so forth. So that gets one thinking, how is it that we're able to transport and recognize that this is pain, this is heat, this is cold? Do you know we don't actually have wet receptors? We can't tell if something is wet. I know.
Really?
It's so crazy to say that because you're like, but I know it's wet because it's water, or I know that that towel is wet because it's this. We don't have hydroreceptors.
So then do we feel the water because of the temperature difference then?
Temperature difference and pressure.
Really?
Hydrostatic pressure and temperature changes and buoyancy. That's what we feel. We do not feel water. Okay, this might turn into a completely different conversation.
That's really interesting though, because like when you wash your hands, you're still like, oh, they're wet.
But you're not actually feeling what wet feels like. I know that's crazy and it's going to blow your mind to hear that. And we might just take pain in the brain and turn it into just how we feel things because it's its own huge topic. We don't have the hydroreceptors that they've found in aquatic life. So when we're feeling water on us, we're feeling our pressure sensors, our temperature sensors, and our joint and movement sensors, kinesthetic receptors. That's what we're feeling. We're feeling the changes to them, and we're equating those three things together, or two of them, as water. Fish feel water way different than we do.
I wonder if air would be the equivalent to that for fish.
It's quite possible. It's quite possible. I would have to look at that one, but because all air is pressure.
Yes, I wonder if that's why blue whales crash or get crushed.
Oh, it's
Because
a
it's just pressure.
possibility. It is a possibility. It's just there's just some crazy things when it comes to how we sense. So this might be less pain in the brain and more how do we sense all the things, right? But every single one of them ends up here for us to interpret. What you can interpret as pain versus what you interpret, say, as a feather. It has everything to do with the different kind of receptors and where they end up inside of the brain. Right? So pressure sensors, there are 5 of them, and each of those 5 pick up a different kind of pressure. And if you don't quite hit the most superficial or the most deep of those 5 pressure centers, if you don't quite hit it and your brain doesn't quite know what it is, it's called tickle. Yeah. There are 2 that are for pain. One that picks up surface level pain, what we call acute pain, and one that picks up deeper pain and is usually chemical in nature. Chemical release in nature, not so much pressure in nature. If you do not quite hit that and your brain doesn't quite understand what it is, that's called itch. Freaking cool, right?
Yeah, it's
Because
interesting.
our brain has to have a very clear signal and it has to be able to relate back to other pain experiences that you've had.
So then how does that relate to being ticklish with deep pressure being a guarding response?
Reword.
So like when there's a really tender area
Mm-hmm.
and you're coming in and they're like, oh, that's ticklish because their body wants to pull back. But really, once you release the area, it's not ticklish anymore.
Mm-hmm.
So in that situation, it'd be classified as a guarding response. How would you explain that then?
Okay, so the guarding response ends up being like, I'm ready for this area to be ticklish. I'm expecting this area to be ticklish, so they're going to guard themselves in an area that's ticklish. Or if their brain doesn't interpret it right away, they're going to jump back because they don't know what it is, and the sensation of being tickled is not a pleasant sensation.
Because like I've had clients that have been ticklish, but they're, oh, I'm not usually ticklish. It's weird that
I'm
I'm
getting
ticklish.
there.
Oh, sorry.
Yeah, I'm getting to that part. Right? But once you're able to go through that area, especially with a bit deeper pressure getting into the deepest of the 5, the Pacinian or lamellated corpuscles, when you're able to get into those deeper ones and do a few things and do a few strokes over top of, the brain interprets it correctly. The brain goes, oh, that's what this is right now. So they stop guarding and they start recognizing what the pressure is, what the sensation is. Unfortunately, because likely they have a loop in their brain that has told them that area is ticklish, it will become ticklish again. Because the brain, as soon as it has that ticklish sensation coded in there, which we usually get when we're very young, and those things that we get when we're very young stay coded for a very long time. It takes a lot to get those codes out. Yeah. So those codes are there. They're probably going to be ticklish in that spot later again. Is freaking hilarious. Right? You have to be very conscientious if you want to get rid of that sensation. Itch is very similar. Itch can be is usually a chemical something. So something that could chemically get a pain neuron, or what we call nociceptor, to respond, but it doesn't send up enough of a signal for your brain to go, I'm feeling pain. It's going, oh, what the heck is that? Comes off as itch. One of the reasons why, things that bite us or things that get to us, especially mosquito bites, their residue that comes off that's like there to help them digest our body perceives as an itch sensation because it's not quite painful. It doesn't reach the threshold of painful in our brain. And then if you do it more and more often, your brain goes, oh, it's a mosquito bite. It's going to be itchy.
Hmm. So then the people that like aren't itchy and mosquito bites just don't even bother them.
The brain is basically able to go, oh, well, this isn't a pain sensation. It was when it bit me, but it's not a pain sensation. But also, I don't recognize it as any other sensation. So it might feel like there's a little extra pressure because there's swelling that happens every time. There's a little bit of extra pressure. They might feel like a little sore because of inflammation that shows up in the area. Yeah, inflammation almost always starts as a feeling of itchiness. Before the brain has time to really understand what's going on. The brain's on a delay. Now, sometimes that delay is milliseconds. But it's on a delay.
That's very cool.
Yeah, it is really neat. And it all has to do with your ability to keep sodium and potassium in good levels inside of your body. Chloride as well, but and calcium. Those are the two other big ones. But yeah, our brains are crazy.
Yeah, they really are.
Tiny little area, roughly about here. See that right there? It's about the width of, like, I don't know, maybe your thickest finger. It just goes down, and it's about, I don't know, the width or it's like the length of your top of your skull to your ear.
Okay.
The thickness of your little finger or your biggest finger, but then the depth of your smallest finger, if you would.
Okay.
And on both sides of your head, and it is responsible for all of those kind of sensations coming from your body. The only things that it doesn't pick up are hearing, equilibrium from your ears, sight, smell, taste. Everything else gets sent up here. Everything from skin, muscles, bone, even the autonomic stuff that you can consciously feel will end up there. So
really,
your gut, the grumbling gut, when your heart beats really, really fast, that all gets processed up here if you can feel it, like consciously know that you're feeling it.
Such a small space for such an important part.
Yeah.
Or such an important task.
Try to remember that every single little neuron that's inside of there is smaller than your thinnest hair. You can't see it with your naked eye. You can pack a lot into that tiny little space.
That's insane. But I guess in relationship to like the size of the brain compared to what it has to control and do, that makes sense that it would have that kind of adaptation. But actually just like stopping to think about it and like putting it in that perspective, it's just like, huh.
Mm-hmm. It's absolutely freaking crazy. Now, we work with mostly muscle, right? Like we do, when I say mostly muscle, what I mean is muscle and connective tissue all together, working all together. We work a little bit with the skin, mostly the connective tissue right underneath the skin. But I have a picture here I want to show you that kind of shows you the sensory part when it comes to the muscles and the fascia that surrounds the muscles, and just how many of the nerves that are going to that for both sensation and motor are these pain nerves versus other kinds of nerves. So I got a picture. I just want to share the screen and show you. Okay, do you see this beautiful?
Mm-hmm.
This is a single nerve going to a single muscle. Just one nerve going to the muscle, right? The easiest one to think about here, I like to think of the auxiliary nerve that goes to the deltoid, because it's one muscle, one nerve, nice and easy. Like really, really simple, right? So Inside of this nerve that's going to our one muscle, we have the autonomics, because every muscle has things that are autonomic. Did you know that? You don't
Yes,
think about skeletal muscle as autonomic, do you?
but they still have to like subconsciously just do their thing.
Exactly.
So it makes
This
sense that they would be.
this right here is where muscle memory comes from. The autonomic motor fibers. You know, when you're swinging your arm, you are not choosing to swing your arm most of the time, right? But if we talk about the deltoid, when you're going to go give somebody a handshake, you're not thinking, "Oh, I need to contract my deltoid." You're
Truth.
thinking, "I need to swing my arm forward." So, some of it comes from the somatic motor fibers because you're making the decision to do that motion. But the speed, the force, all of that, where you're not really consciously thinking about it, comes from the autonomic motor fibers.
Hmm.
Look how many more there are of those to somatic, to the voluntary ones.
That makes sense because the body likes what's easy,
Yeah.
right? So if it can get a replay, if you will,
Yep.
then all you have to do is choose to do that replay.
Yep. Oh my gosh, that just Ponder Replay just started playing in my head. Ponder Replay. So on the motor side of things, and here's another really fantastic. Some of these autonomic motor fibers are not going to have any effect on the muscle itself, but are actually going to have an effect on the sensory fibers. They're going to release things to the sensory fibers to make them do more things. I'll explain that in a second, but look at the sensory side of this. The majority of things going to a muscle are muscular fibers, motor fibers, motor neurons. Then you've got this tiny little section, just this tiny, tiny little bit of the piece of the pie that are for Golgi, Pacinian, and Ruffini. Now, what these guys pick up, the Golgi dudes, these guys pick up the tension of the tendon at the musculotendinous junction. So whether the muscle is contracting too hard and overstretching the tendon in there, or you're overstretching the muscle and it's not responding well enough, so now the tendon is getting stretched. So that's our Golgis. Pacinian and Ruffini, these guys are sending information back as to the actual location of that muscle in the body relative to the world around it. And we don't even have muscle spindles, right? Notified in here. Granted, the muscle spindles are kind of part of all of this as well. Then you have this whole big area with the interstitial fascial receptors. And these guys right here are temperature. These are simple mechanoreceptors for the connective tissue that are very similar to Golgi. These are pain, what we call nociceptors, and they're almost always C type, so they're the chemical type. You really don't see a lot of the mechanical ones anywhere other than the skin, right? So you've got a lot more that is picking up pressure, vibration, and pain and temperature.
So I'm just making sure I'm remembering correctly.
Yep.
The C fibers is a slow, dull.
Yeah, the
pain.
slow, dull pain.
Yeah. Okay.
The slow, dull pain. Right. And then in and amongst all of this stuff, the autonomic motor fibers as well as the interstitial fascial receptors, these guys are also going to the blood vessels that are there. So all of your arteries, arterioles, capillaries, venules, veins, and lymph.
So they would be then assisting with the dilation or constriction of the vessel.
Uh-huh. And that is why the autonomic motor fibers, they don't just work with those things, they will also tell interstitial fascial receptors, specifically these guys. I mean, sometimes the Golgi and everything, but a lot of the time, these big guys, they'll be like, hey, this is a danger zone for our pain neurons, say, this is dangerous what we're going through right now. You need to continue to send things up to the brain until this sensation has stopped, right? Or until the body fixes this.
So that would be so with the Golgi tendon, that would be because it's um oh my goodness, contraction of the muscle. That's
Yeah.
what the pill is. Yeah.
Over contraction of the
So
muscle or overstretch of the tendon.
right. So then with that, but the stretching overstretch, sorry. So then they would be working together then. So
Mm-hmm.
as a Golgi tendon, it's like, oh, this is too much. We're not happy here. We're not happy here. And then those proprioceptors in the interstitial fascia would be like, yeah, we're not happy here either.
Mm-hmm.
And then it would just kind of just go back and forth until the brain caused that muscle to relax.
Basically, and the brain doesn't have a great trigger to cause relaxation. What it does is it sends inflammation to the area. It opens up the blood vessels, which is where we need those autonomic nervous fibers. They'll open up. They'll send in first the neutrophils to check out the area and go, okay, what can we do here? Can we lay down new stuff? Do we need to fix anything? It'll be increasing the number of platelets that are in our body to fix any blood vessels that might have got damaged. It'll go in there and it will just try to fix things. And if it can't fix things, if there's nothing to fix, then and whatnot. So sorry, I shouldn't say nothing to fix because there's always going to be something to fix. In that, if there is something that is getting your pain neurons going, that means there's something wrong and the body needs to fix it. Usually, that something is the muscle's gone into a spasm because we tried to overstretch the muscle. So the muscle's gone into a spasm of some sort, and that spasm is cutting off blood flow. A lack of blood flow means a buildup of things that our muscles don't like having buildup of: lactic acid, carbon dioxide, blah, 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 enzymes.
What is this? Blah, blah,
blah, blah, blah. Does all this wonderful stuff. So it sends in, it tries to send in inflammatory agents to figure out what the heck is going on. It doesn't have a relax muscle button. It does what the body does when there's something wrong, and that is send inflammation. It's our body's non-specific response to literally everything. Right? And our muscles, if they go into that spasm because of whatever reason, whatever it might be, it could be overuse injury issues, it could be a big trauma issue, whatever it is, right? Until the causative factor has been removed, that muscle will stay in a contracted position. It will stay in that spasmodic position, even if it's just 3 or 4 fibers. I'm not talking the whole muscle. It could be 3 fibers. It could be, if the fiber was as long as my arm, it could be, the whole thing. That's a muscle, right? It could be 3 or 4 fibers, and it could be this part of that 3 or 4 fibers. Just this part. It doesn't even have to be the whole fiber. It could just be this tiny little part of those 3 or 4 fibers that are constantly in spasm, constantly shortening, constantly having too much tone inside of them. And that could cut blood supply to that little area and cause that area to have a buildup of things that our body doesn't like. And that buildup of stuff, lactic acid, carbon dioxide, guess what? Pain nerves don't like those.
And then we are in a vicious cycle.
It just keeps going, going, going.
Like Desert Bunny. Muscle style.
Oh, it is so ridiculous. So our brain does not have a relax button, right? You know what does help us to relax? Consciously doing it. You can consciously relax your muscles. For anybody who has never heard this before, right? Now, are you going to be able to fully relax them? No, because a fully relaxed muscle is a flaccid piece of crap that doesn't work. You do not want a fully flaccid muscle. You want a soft rubber muscle. That's how I describe the muscles that feel good. They feel kind of like soft rubber. Like a really nice, pliable, soft rubber that you can move, you can stretch, you can bring back. It feels really nice. There's no bumpy lumpies in it. Nothing like that.
I can support that description.
Yeah.
Yeah.
I like it. That's how I explain it to clients. They're just like, oh, this feels like concrete. So what I go with, because bone is harder than concrete,
Mm.
and there's sometimes that muscles feel almost as hard as bone. So I go concrete. I go, this is concrete. We need to take this concrete, move it to asphalt. Then we need to make that asphalt and move it to hard rubber. Then we can take that hard rubber and move it to soft rubber.
That works.
That's how my brain and like if they keep up on home care and stuff, I can always tell because it'll go from the concrete to the asphalt that I made it, and then when they come back and see me, it's still asphalt. And it's not back to concrete.
Fair enough. Yeah.
Yeah. It was fun. Man, this pain in the brain just went in 5 different directions today.
We kind of knew it would, though, right?
It always does. I mean, we have an idea of what we're going to talk about, but it always goes 50,000 different places.
Well, especially with something like the brain.
Yeah. Oh my gosh,
Like,
the brain is crazy. It's just absolutely crazy. So, the best way, if you don't have anything around you to relax your muscles, the best way to relax your muscles is number 1, breathe. I'm talking deep box breathing, or like I love the box breath. It's my favorite, 100%. But if you're finding the muscle is having issues, breathe, put heat on it, stretch it. Right? Now, this works for almost every muscle in your body. Unfortunately, we do have some muscles that have a tendency to overstretch. So breathe, put heat on it, stretch it, strengthen it. And those would be called phasic muscles. You can look up a list, literally, you can go on Google, look up a list, make sure that you get it from a decent site like Natural Health Institute or National Institute of Health, NIH. They're good. They're a good site, reputable. But yeah, there are phasic muscles, and these phasic muscles, they have a tendency to get long and tubey, and like instead of feeling like either concrete or asphalt or stuff, they feel like metal tubes. Not even metal tubes. They this is gross tube feeling. What?
like bungee cords.
Yeah, they kind of feel like, but even worse than bungee cord. You know what? Do you remember? Did you? I don't know if you. Anyway, they're like thick plastic tubes that like you can feed water through. They're kind of like straw, almost like the straws, like plastic straws. But
The
like
black
the
one?
thick plastic straws that can kind of bend a little.
Oh, the whoopy ones?
Yeah, well, no, not the whoopy ones. They don't whoop. They man, how do I describe? There's such a better way to describe this. I'm thinking of the tubes that I used in like 8th grade when I had to make a circulatory system. They're bendy, but they're hard. Oh, man.
If I saw one, I'd probably be like, I know what you're talking about.
It's kind of like the new type of tubes that they use for plumbing, those blue and red like bendy tubes that they use for plumbing that are really, really strong, but also flexible. But without little, you know, kind of feels like this. This is just a cord.
Yeah.
That's what it feels like. That's actually a really good. Imagine this under skin. Feel a thick cord. Imagine that under skin. That is what stretched out muscle feels like to me. I can't believe I didn't think of that before because it's like literally right beside me.
I'm gonna have to use this for reference next time.
Yeah. My husband has tendonitis. And the tendonitis comes from overuse and overstretching of the extensor tendons up here.
Mm.
And literally, it feels like he just has a whole bunch of extension cords running through his arm. That's actually the best way to do it. Yeah, extension cords. Cords and like anything that's cord like. It just feels like those cords. It's really ridiculous how I've never done that before. And in my mind, it was tubes.
Well, of course, they're kind of tubey.
Yeah, well, that is true. They're kind of tubey.
I don't know. I'm gonna have to pay attention. I never really thought of it like that. I just kind of.
The next time you find somebody who has hyperkyphosis or like an increased kyphotic curve, not even a big one, but you think that their back is really weak in that area for rector spinae, go like this on it, lengthwise. right? Like so transversely over it and feel the tubes.
Yeah, like yeah, I always thought
Totally.
of I guess I always think of them as ropes, but I guess ropes and tubes you're just cutting at straws.
Yeah, honestly, that
Yeah.
is true. I find that rope doesn't have the same texture as tubes and cords.
Yeah, it's smoother. I guess rope is more lumpy.
Yeah,
I can see that.
yeah. I think of rope when I think of ropes and twine and stuff. I think of connective tissue, not the muscle,
Oh, okay, fair enough.
right? Which 100%. I mean, heck, scar tissue.
That's what it
It's
is.
all ropey twine.
Yep. So
So
best for
funny.
stability.
Oh yeah. Oh, yeah, this one went in 5 I didn't even use any of the other pictures. That was the only picture I ended up using that I got
Oh,
prepped. That's so funny. Oh my gosh. But yeah, this is sort of a precursor here to what we're doing in March with CMMOTA, also known as CMOTA, where we're going to talk about pain in the brain. And I'm going to go through a much more structured version of this. So if you are with CMOTA, go check that out. Even if you aren't with CMOTA, they usually have this open to members at a certain price and then non-members at a different price. So if you're interested in coming to watch that,
should go check it out.
uh, it will actually stay in the information of pain in the brain. And it won't jump off into 5 different ways. Like we don't have water receptors in us. But isn't that cool? We don't have water
That's so
receptors.
cool. I love that.
Mhm. We have
I love that so much.
mechanoreceptors, we have interoceptors, we have exteroceptors, we have nociceptors, thermoreceptors, photoreceptors, chemo. Like we have so many other things, not hydro.
Hmm.
Mhm.
Well, I guess you know what makes sense. Ever since you said that, I've been like feeling my mouth. I was like, it's wet, but
Yeah,
it's right.
but how
I don't feel the saliva
you feel
unless it starts
pressure.
to pool,
Yep. And the
and like
pooling causes pressure.
yeah, and then that's like, oh yeah, I have to swallow, but I don't feel it otherwise. Like now I'm like hyper fixated on it, but it's just part of what it is.
Mhm.
Yeah, that's so interesting.
So freaking cool.
Like even when you go pee, you don't feel, oh, this is wet. You're just like, oh, I'm peeing.
It's
You just know.
pressure, temperature, and when you're
Yeah, that's
actually
so
in water, when it's
interesting.
altering how your body functions in space and time, it's Ruffini and Pacinian and Golgi's that are feeling the difference.
That just blows my brain.
I
Actually, I love that. Thank you so much
You're so
for
welcome.
sharing that with me. I can't believe that we haven't got on this topic before, but thank you for sharing that with me. That's
Oh, you're very
very
welcome.
fascinating.
That was a fun one.
Fun
Yeah,
fact.
yeah. I feel like we could have gone that way for the whole
Yeah.
podcast.
Yeah, we definitely could have. I was gonna go there and I was like, no, 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 no. Pain in the brain. Pain in the
Pain in the
brain.
brain. I
We
don't
could talk
really
about
care. We
touching
can
the brain next time.
touch the brain, all of the sensation receptors in the brain. Oh my god. What are we talking about next time? Let's go to Trello, find out. I think I'd keep these in my brain, but I really don't. Oh, next week we have our um we're just talking about cases. We're talking about all the stuff that we want to bring up with different cases that we have, and we have a special guest next week.
That'd be fun.
Yay!
I'm
So stay
excited.
tuned for our special guest of the week who will be joining us next week. We're keeping it a secret right now.
Hmm.
um. So yeah, I think that's good. I'm happy. It was a good chat.
It was a good chat.
All right.